Welcome to the COPD Foundation podcast. We bring you insights from leading health professionals, inspiring stories from those living with lung conditions, practical advice, and the latest in lung health research. Be sure to subscribe, follow us on social media, and visit copdfoundation.org. Take action today, breathe better tomorrow. Just a quick note before we jump into our topic. This podcast series was created for educational purposes only and is not a substitute for formal medical advice. Talk to your healthcare provider if you have any questions.
Hello, and welcome to this episode of the COPD Foundation podcast. I'm Amanda Atkinson, an educator at the COPD Foundation, and I'm joined today by Dr. Kyle Hogarth. In this episode, we will tackle some common myths and facts about COPD and Alpha-1 antitrypsin deficiency. Dr. Hogarth, can you tell us a little bit about yourself?
My name is Kyle Hogarth. I'm a professor of medicine at the University of Chicago, pulmonary medicine, of course. I do run a specialty clinic centered around Alpha-1 antitrypsin deficiency, but I also obviously work closely in the field of COPD and severe asthma. And in particular on COPD, because I wear the other hat of interventional bronchoscopy, actively involved in clinical trials for devices to help people breathe better with advanced emphysema, such as valves, which are approved, but then other devices that are coming their way down the pipeline. So the long and the short of it is, if you have an obstructed lung disease, whether someone's calling that COPD, emphysema, asthma, et cetera, something in that flavor, I see patients like that.
We're so glad to have you with us today, so let's jump right in. One of the main myths that we hear with relation to COPD is that it's strictly a disease of older individuals with a long smoking history. This thought process often leads clinicians to be hesitant to test younger individuals or those with little or no smoking history as a first line of investigation. Can you shed some light on the actual facts about COPD testing and screening?
So you're right. There's a huge myth about COPD and then Alpha-1 and hand in hand with that. And one is this notion of an age, cutoff, et cetera, of when you should test or not test for both, symptoms as well as for the underlying genetic causes. So let's start with some realities. Obviously, smoking is a predominant risk factor for the development of COPD. And so without a debate, don't smoke. If you are, quit. But other things too. And when it comes to the lungs, smoke is smoke. So more and more states have legalized marijuana. And inhaling as a smoke, marijuana is just as toxic to the lungs from a COPD perspective as tobacco smoke is. There's data from New Zealand that backs this up. The data is still out on how severe vaping is for the lungs, but it's clear that it's damaging to the lungs. So it's all relative in the sense of, yes, you're going to still be damaging your lungs with vaping. Maybe not as much as cigarettes, though. That's like saying, I guess, I'm going to get hit by a car instead of a bus. I'm going to just choose not to get hit by either. And then, of course, what's harder to quantify, smoke, secondhand smoke, environmental pollution in regards to particulate matter, particularly from diesel fuels or coal burning plants. Polluted environments, biomass fuel. So for people in parts of the world with poorly ventilated homes that are cooking over a biomass as opposed to a well-ventilated oven or stove, that's a significant exposure as well. There's clearly genetic factors, Alpha-1 being one of the big ones, but other genetic factors that we may not have a name for yet, but we do know that lung disease can travel in families through these risk factors. There's obviously occupational exposures, both directly in regards to pollution, but in otherwise. And then there's, without a doubt, I'm sure, factors that we haven't even thought of yet or haven't yet discovered from a research perspective. I think the long and the short of it is, though, is that if you've had a significant exposure history or any amount of smoking history, so pick any kind of an exposure, you should not have trouble breathing. You should have the expectation of normal breathing capacity. Yes, your lungs have a predictable amount of decline as you age, but that's not supposed to leave you having the inability to walk places or go up the stairs or get winded walking around the grocery store and things like that. And as we all know, unfortunately, a significant amount of COPD is found in still relatively advanced stages. And, there's a lot more we can do for any disease when we find it in an earlier stage. So when in doubt, if you feel like you have an even a hint of trouble breathing or symptoms like that, it is worth doing spirometry, which is the only way to truly prove you have COPD. And if you do, then at the same time, finish the workup for it. And at a minimum, get an Alpha-1 antitrypsin genotype testing, genetic testing, to see if you have the genetic risk factor on top of the environmental risk factors for the development of COPD and emphysema.
Dr. Hogarth, you just alluded to another common myth that we hear from many individuals, which is that it's normal and even expected as you age that it will become harder to breathe. As a clinician, can you tell us how you'd approach the conversation with a patient who's reporting some increased work of breathing and who's believing this myth?
Yeah. So, I mean, it would be a question of asking, say, are you able to do the normal activities around your home and around your yard or at work that you want to do? Do you play any sports still of any kind? I'm not talking about whether you play well. It's just, can you still keep up? What do you feel like climbing up one flight of stairs in your home or, at work or whatever? And look, here's what'll happen. Statistically, someone who maybe had whatever exposure will tell you, oh, sure, I get a little winded going up the stairs. And maybe that is because they've put on weight, they've stopped exercising, and they're indeed out of shape. They're deconditioning. Fine, great. That's a fixable problem. I hope that's all it is, right? But if you tell me this and you've had a smoking history, an exposure history, all the things we went through already, order the spirometry. It's a simple test. It's the only way you're going to diagnose COPD. You have to actually prove there's obstruction. So when it comes back normal, fantastic news, right? I mean, it's the rule out approach. Look, I do lung cancer screening. I'm excited when the scan comes back normal. That's the greatest thing on earth, right? So when you find out that your patient doesn't have lung disease, awesome. If there's no signs or symptoms of heart disease, then tell them to hit the gym and lose some weight and get exercising. That shortness of breath will go away because they're out of shape. But my gosh, if they have lung disease, diagnose it now. And then, if they're still smoking, that might be the motivator to help them quit. You can get them on the appropriate guideline-based inhalers. You can do the workup, et cetera, depending on how much they've smoked. Maybe they are a candidate for lung cancer screening. The list goes on. The whole idea of this is primary prevention, right? And it's a lot easier to deal with COPD when, again, they're in the early stages as opposed to more advanced stages of the disease.
Unfortunately, myths are not exclusive to COPD. There are a lot of misconceptions surrounding Alpha-1 antitrypsin deficiency. Dr. Hogarth, can you address some of these common misconceptions?
The list is quite extensive. And I hear it from physicians all the time. And actually, if you talk to patients who've been diagnosed, they'll tell you the same myths because many of them, unfortunately, had to go years and see multiple healthcare providers before someone just did a simple blood test. So, the problem is it's on one level, it's not everyone's fault here. And what I mean by that is during your training through your healthcare profession, no matter what you do in healthcare, what you learned about Alpha-1, if you were lucky, was maybe one sentence, two at most. And you were told that it was advanced emphysema, if not end-stage emphysema, presenting in someone under the age of 45 who barely smoked. That's the usual jargon that gets thrown out about that disease. So what I'll say right up front is, did you really need all of your education to know that a 40-year-old barely smoker should not be dying of emphysema? I mean, isn't that sort of obvious to everybody, right? So that's the biggest red flag already if you've got that in front of you. But the reality is, as we all know, a significant amount of smokers, in fact, the majority of smokers, don't develop COPD, right? That's pulmonary's little secret. There's plenty of other bad things from cigarettes, obviously, but COPD, by definition, if you've smoked and developed COPD, you have some level of a genetic predisposition to the development of lung disease from tobacco smoke or any other smoke. So it may not be Alpha-1, but at a minimum, go rule it out. And of course, there are genetic implications for the family, and equally important, there are therapeutic implications. So Alpha-1 presents clinically at any age. You first got to diagnose COPD, right? You got to prove there's airflow obstruction. So that goes back to that, hey, there's symptoms to the spiro. There's this notion of a trivial amount of smoking. The average pack year of an Alpha-1 patient at the time of diagnosis is 24, with a plus minus on that of at least 11. So that guy you saw this morning with 30 pack years of smoking, how could he have Alpha-1? He very much can have Alpha-1. She can too, because it's not a sex-linked disease. I've heard that myth. It's men and women equally. It's every single race and ethnicity. That's the other big myth. I've heard my clinic is, I only see, insert whatever, group you want to put in there. This disease has been described in every single race and ethnicity around the entire world. So wherever you draw your heritage from, whatever you like to call yourself, that's great. Alpha-1 doesn't care. So we test anybody with obstructed lung disease. This is the guidelines. These are the gold guidelines. These are the Alpha-1 guidelines. It is the management of obstructed lung disease. It deserves a workup. And look, it's a genetic disorder. It's uncommon. I always hear the term, it's rare. It's not rare. It's uncommon. And what do I mean by that? Well, so in the United States, the carrier rate's anywhere from about 1 in 15 people to maybe up as high as 1 to 30, depending on whose numbers you like to look at. That ain't rare, right? And carriers who smoke have a 10-fold higher risk for the development of COPD. And so when you find a carrier, there may not be direct therapeutic implications, but there are some profound implications on helping with smoking cessation and adherence to pulmonary medications. And of course, given the carrier rate so high, there's a decent chance that you're having children with another carrier, which means then your children might indeed have Alpha-1, and the list goes on and on, right? This is a very interesting basic Mendelian genetics. So it presents as COPD, chronic obstructive asthma, emphysema, bronchiectasis, and also liver disease. That's the whole other component of it. The long and the short of it in our own practice, the teaching's always been, if I'm prescribing inhalers to you, that I already think you're obstructed in some way, and I've proven it through spirometry. So then I do finish the workup. And look, the COPD guidelines tell us we should be doing a CBC to check for eosinophils. The chronic obstructive asthma guidelines say the same thing. You should draw a CBC, maybe an IgE, et cetera. Bronchiectasis, you're already going to draw some other blood work. Why wouldn't we just add this? Even if you never think of Alpha-1 in your life, rule it out. You know, and I use the words rule it out pretty specifically because I think about, you know, everyone who's watching this. How many times have you ordered an EKG or a, you know, CT scan, you know, for PE or whatever, pick something, EKG to rule out MI, versus the number of times you legitimately found that someone was having a heart attack, or you legitimately found a blood clot, or anything else that you've ordered just to ensure it wasn't there. Look, I know statistically the guy in front of me is not going to have Alpha-1, but there's only one way I'm going to prove he doesn't have Alpha-1. I'm going to test him, right? And if nothing else, you know, the direct-to-consumer market tests for Alpha-1. So, you know, if your patient with lung disease finds out that they've got Alpha-1 and they found it themselves, something else, that's mud on our face as a profession, right? So we can do better. And this is guideline-based. This is not some agenda of any doctor or the foundation or any of that kind of business. This is the guidelines. So I think that's what makes it even more important. You know, and look, when they don't have it, great news. Whatever lung disease they have, it's just good old-fashioned, you know, generic COPD. No disrespect meant, but it's not genetic COPD, which is different.
Speaking of genetics, another common misconception that we hear from patients is that family testing is not necessary. Many clinicians hesitate to really emphasize the need to test family members when someone's discovered to have Alpha-1. And we know that as clinicians, we'll always have opportunity to grow in our communication and our conversational skills with our patients. So, Dr. Hogarth, what would you say to someone who's on the fence about family testing?
Well, it's a genetic disorder, right? I mean, so goodness gracious, you know, you got that abnormal gene, one or two of them from mom or dad or both. Mom or dad potentially has brothers and sisters. You have brothers and sisters. So you've got nieces and nephews and cousins. And I mean, the list goes on, right? You know, mentally just draw out your family tree right now, right? Go up just one side of your family tree. And holy cow, there's a lot of different family lines that have come into your family tree, genetically speaking. And again, with the carrier rate as high as it is, you know, and it's funny when you talk to alpha patients, the ones who really get into the, you know, they'll kind of use this to spur a genealogy discussion, right? They'll just start, you know, I mean, I think we're all kind of on one level interested in your family history and not just for the whole, like, hey, you know, am I related to some, you know, former king from the 1400s or whatever, but you're interested just your heritage. It's kind of interesting. And what better way to also tie yourself to parts of the history of your family, you know, from ancient times to, you know, relatively, you know, recent times, than pulling together, obviously, genetic risk factors. And I think, you know, I put it as a different way, you know, from a physician's perspective, from a patient's perspective, we all know what runs in our family, right? You know, hey, everyone in this family gets, you know, we have to get screened for colon cancer. You know, it may not be a genetic risk for colon cancer, but there's a lot of colon cancer in the family. Okay, fine. Everyone has heart attacks in this family. Okay, fine. we all are going to watch our cholesterol, blood pressure, et cetera. You know the family lore. Well, lung disease is no different. And again, there's a genetic component to it. It may not be Alpha-1, but I can take that off the table real quick. But wouldn't you want to know? And especially, the thing that's interesting to me about Alpha-1 is there's treatment for it. In what world do I want my patient to be walking around with a disease that I'm not managing? Ever, right? I mean, ever. I want to manage your blood pressure. I want to manage your cholesterol, your diabetes, et cetera, your weight loss, get you to quit smoking, get you your vaccines, primary prevent, other cancers, right? Mammograms and pap smears and colonoscopies and prostate, et cetera, et cetera. In what world would I not want to be looking out for your lung health? And the fact that it ties to your whole family, that's just common sense. And again, the carrier rate's so high. If I told you that if you're a carrier, that there's a 1 in 15 chance the love of your life might also be a carrier, that doesn't mean you're not going to have children, but it does mean you're going to be at least smart about how you raise those kids and the environment you raise them and the way you test and follow for them, right? I mean, it's a cliche that knowledge is power, but when it comes to genetics and Alpha-1, it's beyond powerful to know what you're at risk for.
Speaking of risk of disease, another common area of misunderstanding that we see is the overlap between COPD, Alpha-1, and bronchiectasis. What would you say to clinicians who might not be aware of the prevalence of that overlap?
So bronchiectasis is an extremely multifactorial disorder, right? And there's lots of different ways that people develop bronchiectasis. Some are just classic post-infection damage done to the airways, say from like tuberculosis, actually one of the most common reasons worldwide. But there are obviously predisposing factors, and there's a whole bunch that we don't know the name of, right? When someone tells you you have idiopathic bronchiectasis, idiopathic is a fancy way, right? We all know of saying we don't understand. But there's a workup for bronchiectasis. There's a workup for people that then have that bronchiectasis with an NTM infection. And, do they have an immune globulin deficiency? Sure, it might be. We can test for that. Do they have Alpha-1 antitrypsin deficiency? Yep. Do they have a genetic variant of cystic fibrosis? Not one of the classic ones. Maybe. And the list goes on. Do they have immotile cilia syndromes? And that's a long list of different possibilities as well. Everything's rare until you go looking for it, right? I kind of make the joke that in my pulmonary practice, I have no diabetics, because I don't check blood sugar, right? Obviously I have diabetics, right? But if I never looked. So, when people say, I have no Alpha-1 in my practice. Well, there is only one way to diagnose Alpha-1. That's with a blood test. If I diagnose bronchiectasis, the next question is, why do I have it? Well, if I don't do any workup for it, then I haven't done my job. You just have bronchiectasis, right? A diagnosis without the follow-up workup afterwards is still not doing your patient a service, especially if there's modifiable reasons that they have whatever that diagnosis is. Alpha-1 in regards to the bronchiectasis or emphysema, or say it's common variable immunodeficiency that's causing the bronchiectasis. We got treatment for that too, right? So, it's not just saying, oh, you have this, it's why, and then what I can try to do to modify it so it doesn't continue to worsen.
We often hear people saying that diagnosing Alpha-1 is easy, which is truth. It just takes a simple blood or buccal test to determine genetics. But one thing that we run up against is the amount of time from symptom onset to when someone's actually diagnosed. Unfortunately, it's very common for us to hear from the patient community that it took years and multiple providers for them to receive a diagnosis of Alpha-1. So the truth is, diagnosis is easy. The myth would be that it's fast. But as clinicians, we can change that.
Yeah, so the data is actually, unfortunately, it's everywhere from almost 7 to 8 years. And the average person has to see 3 different healthcare providers before someone finally draws literally one blood test. And I think about it this way. Everyone who's listening and watching, when the last time you saw, someone within healthcare, nurse practitioner, PA, doctor, anybody, whether it's your primary, a specialist, don't know, don't care. Did they draw blood on you? Yeah, probably. Check your lipids, thyroid, basic metabolic, whatever, right? But if you have lung disease, you're listening to this, then why wasn't the workup done? If I just told, if I go into my primary and say, I have heart disease and I'm a brand new patient, that person better be checking my lipids, right? So they're drawing blood on me anyway, right? So why wouldn't we overcome this burden, this barrier? And again, I always say, look, if I could go the rest of my career and never diagnose another Alpha-1 patient ever, that'd be great. I don't want anyone to have this disease, right? I don't want anyone to have COPD, but I've already diagnosed your COPD, right? So we got that. And then in my dreams, I'll never diagnose another Alpha-1 patient again. It's a genetic disorder. It has its own problems. I don't want you to have this. But until I do the blood test, I have no idea if you have this. And because the odds are still pretty good that you do, I can draw blood, prove you don't, wipe our hands of this. Regular COPD, great. I got terrific meds. I got great guidelines for this, right? If I find out for your bronchiectasis workup, everything goes back negative. I have no clue why you have bronchiectasis other than you have it. Okay, fine. We're going to manage it. I got things to help manage it. You just won't get some of these very specific therapies that are geared towards the underlying cause.
We know that Alpha-1 impacts the liver and the lungs, but many have a misconception that those are the only organs that are impacted.
Sure. Well, there's definitely the classic teaching it's been liver or lung, never both. There was the liver affected people at an early age. It was a childhood disorder, et cetera. And so don't worry about it if it doesn't happen. Well, that's not true. It's definitely a cause of adult onset liver disease, independent of any other factor. So sure, if you also drink a lot of alcohol and you're obese and so forth, that's also bad for your liver. So being an alpha won't help that either. But liver disease can happen independent of any of that. And so, knowledge of Alpha-1 so we can monitor for your liver appropriately is extremely important. Yes. Interestingly, there's a lot of research and development going on in the Alpha-1 liver disease field right now. So there's potential opportunities for patients who may be developing Alpha-1 related liver disease. Alpha-1 is also related to a very uncommon skin disorder called necrotizing pediculitis. These painful lesions that break out on the skin. It's usually ultimately diagnosed by dermatology because it's not responding well to conventional therapies. But if that's ever being found or considered, then please, without a doubt, do the Alpha-1 workup. We already talked about bronchiectasis, chronic obstructed asthma, emphysema, COPD, any degree of airflow obstruction. And when I say chronic obstructed asthma, I'm not talking about someone with mild disease who puffs on an albuterol once in a while. These are the people who on spirometry have fixed airways disease. They've remodeled. And trust me, when the Alpha-1 comes back normal, the level, the genetics are normal, great. Then you just have really severe asthma. That's a problem in its own right, but luckily we've got good drugs for that too. And we can help manage that. But when, of course, it's Alpha-1 related, and one of the reasons your asthma and your airways are getting damaged repetitively over and over is we've been not appropriately managing the underlying cause. So, one blood test that's a standard of care and part of multiple guidelines to help prevent progression of multiple other diseases, it's not a big sell here, right? And, what I always caution people, so I hope you're going to listen to this podcast, and tomorrow in clinic, you'll be like, yeah, I'm going to send this. I'm sending that Alpha-1 test 20 times tomorrow because I'm going to see 20 new asthma, COPD, emphysema patients, whatever. And guess what? All 20 are going to come back normal because that's the nature of statistics. I say 1 in 15. Yeah. You can also flip the coin multiple times and not land on heads, right? I mean, this is just probabilities. And so I've had people I've given presentations and I've had people then later come up to me at another presentation or a conference or something I'm presenting at and almost, I won't say belligerent, but definitely a little, angry. I said that test 30 times. I didn't even find somebody. Maybe reorient your thinking on this. I'm glad you sent it 30 times. I'm also really glad you didn't find anybody, right? But by the way, I'm assuming you didn't close your clinic after 30 patients. So keep going. You will find someone. It's actually really interesting. I share this story when I was in my training. So I was in my fellowship, and it was definitely a while ago. And we started just testing everybody because that's what the guidelines said. No one was doing that, but I started doing it. And so I presented a poster at one of the pulmonary conferences where I said, hey, this is what happens if you just start testing. Don't overthink it. With all due respect, be kind of dumb about it. Obstructed, blood test. Obstructed, blood test. And lo and behold, we were finding a patient every 2 to 3 months. And I had clinic once a week because it was a training program, so it wasn't even that much clinic. So I presented this, and a guy came up and he's reading my poster and he's looking at it, he's looking at me, and he keeps saying to me, he goes, really? Yes, really. He's like, really? He didn't believe it because he'd been practiced for a while, never seen an alpha. So I get a phone call from this guy 6 months later, and he says, you may not remember me, but I was at your poster. I said, no, I remember. He goes, yeah, I've been testing everybody. He's like, I found 6 people in the last 6 months. He's like, I mean, and that was it. And he's like, and all these other people didn't have it, which is great. And I found a bunch of carriers and I helped them quit smoking. Like it made me feel really good because all I had was a dumb poster up at a conference, right? But I, at least in one part of one state in a town, changed how a guy practiced and changed, then obviously at that 6-month mark, 6 people who got much better care. And, that made me feel real good as a clinician. And I guarantee you his patients felt really good about it. And that was cool. As he got obviously involved more in COPD and Alpha-1. And it's a great story.
Yes, that is a great story. And I bet it was not just that one physician who decided to test. Imagine how many families were impacted in a positive way by what you shared. Are there any other myths that you commonly come across related to COPD or Alpha-1?
Yeah. So one of the most common things that I hear that's wrong is, and I'll be presenting on Alpha-1, for example. And a clinician will say to me, all right, I heard what you said, but I'm not going to test everybody. And I know that's the guidelines, but I'm not going to do it. What I'm going to do is test the people that seem sicker than the amount they smoked. Now, the crazy thing about that is when you talk to Alpha-1 patients, the smoking history is all over the place. So one, there is no universal amount of illness based on smoking. But again, as I said earlier in this podcast, only 25% of smokers develop COPD. So what I'm actually always shocked at is how healthy some people's lungs are, despite how much they smoked. Now, they'll have vascular disease, they'll have cancers. Again, I mean, there's nothing good about a cigarette. But the fact that most people, on average, have better lungs than they should for the amount they smoked. So in what world are you able to calculate how sick someone should be based on the amount they smoked? So that's why the guidelines are very clear. It's regardless of smoking history. I don't care how much exposure you've had, direct, indirect. You got obstructed lung disease, period. You've got COPD. This is the workup. That's it. You've got heart disease. I'm checking your cholesterol, checking your blood pressure, checking your A1C, right? Well, you would never not do that. So why is COPD so different? I mean, I'm still shocked at the number of people who come to my practice with a diagnosis of COPD who've never in their life had a spirometry done, never had any pulmonary function testing. They come, well, my doctor said I couldn't breathe and I smoked, so I must have COPD. Well, they were partly correct. You may have COPD. Let's do some spirometry. And sometimes, indeed, they do. And then we do the workup, do the Alpha-1, plug them in, go. But also surprising, often the spirometry comes back stone cold normal, that their trouble breathing might be actually a sign of heart disease. They're anemic. Or they're just horribly out of shape. I mean, the list goes on, right? There's a workup. But the spiro is the first step. It's in the definition of COPD, for goodness sake. Presence of airflow obstruction. You have to have it. You have to prove it. Symptoms aren't enough. Symptoms are what prompt you to go do the test. And when you find the COPD, manage it appropriately. The GOLD guidelines are a terrific playbook to help guide you and I on what meds, plug them into rehab, vaccinate, test for Alpha-1, et cetera. All right. And if it's advanced enough disease, there's obviously advanced therapies for this beyond the medications. Lung volume reduction, whether that's bronchoscopic or surgical, the transplant, et cetera, right? There's a massive amount of things that we have for these folks.
Dr. Hogarth, thank you so much for joining us today and separating COPD and Alpha-1 fact from fiction. In our last few minutes, is there anything else that you'd like to say to our listeners?
I appreciate it. No, I think, it's from the clinicians that are listening, if you take nothing from my talk today, spirometry is required to make this diagnosis of any obstructed lung disease. So please do them. Get them in your office or order it, et cetera. And then once you find obstructed lung disease, finish the workup. Draw the eosinophils. If they're an asthmatic, also add the IgE. Do the Alpha-1 genotype. If they're bronchiectatic, do the rest of the workup as well. And then grab the guidelines and treat appropriately. If they're advanced disease, make sure the inhalers and obviously the pulmonary rehab. But then also don't forget bronchoscopic lung volume reduction has broad applicability. It's not just your end stage advanced, emphysema patients. It actually has a lot of efficacies in the more moderate to advanced stage, not just your end stage. And when in doubt, ask questions. Feel free to reach out to me. I'm sure my contact information will be attached to this podcast. Send me an email. I'm always happy to help. So thanks so much for this opportunity. I appreciate it.
You've been listening to the COPD Foundation podcast as we discuss some common myths and facts about COPD and Alpha-1. For more information about COPD, Alpha-1, and other lung conditions, visit the COPD Foundation website at copdfoundation.org and our other social media channels. The COPD Foundation has a wealth of resources for both patients and healthcare professionals. Until next time, take action today, breathe better tomorrow.
Thank you for tuning into the COPD Foundation podcast, and remember, whether you're managing a chronic lung condition, providing support to those who are, or just want to learn more about lung health, the COPD Foundation is here to support you. Be sure to subscribe to this podcast and follow us on social media. Take action today, breathe better tomorrow.